us this morning.
Thank you very, very much. And as we were scrolling through the list of participants, if I could have just an instant of personal privilege, one of the other programs the Medical Foundation and Medical Society do is our Youth Leadership Forum on Medicine. And Casey Clendenin and Bethany Condra both went through that program some years ago. And so it was really exciting to see that they're with us today. We had to sort of go on hiatus because we couldn't do the shadowing component of it within hospitals, but we're hoping to be back this summer with that program. And we now also have students in medical school, nursing school, residency programs. So it's just exciting to see some folks that we've known in the past on this website. Let me see if I can share my screen here. There we go. And let me see, slideshow. I'm just terrible with this, but okay, great. So yeah, today I'm going to talk a little bit about improving access to care for the uninsured, specifically with details about the Project Access model, which we started in Hamilton County. I started working on it in 2003, and the program actually saw our first patient in April 2004. We've also helped start the other Project Accesses in Tennessee. At the end, I'll show you where those are. And we are working feverishly to make it available to some of the surrounding counties. So we hope to get that launched soon. So first of all, I thought I would talk just very briefly about why is a safety net needed, because all the programs today really are safety net programs. And a lot of people in our county and the surrounding area don't have health insurance. Many of our patients work in one or two or more low-paying jobs that don't provide them access to care, and they earn too much to qualify for programs like TennCare, but they don't make enough to be able to pay for insurance and afford other basic items. So I'm really excited to see the Care Connector, because health issues are much broader than just access to care. A lot of people in the general public think that TennCare covers everything, and this is just a recent snapshot of who TennCare does cover. About half of the births in the state of Tennessee are paid for through TennCare. If you're a child, you can qualify. Pregnant women qualify if you have disabilities, and some older adults qualify, or parents of minor children, or if you have breast or cervical cancer. So it's very specific, and there's a widespread and misconception that everybody can qualify for TennCare. They don't. And then the other thing is, we dealt a lot with people saying, well, why do you need a program like Project Access? Because the Affordable Care Act makes insurance available for everybody. But there's some really big gaps. The Affordable Care Act presumed that states would expend the equivalent of what a TennCare in our state. And so it provided for marketplace subsidies for low-income individuals, but there's a great big gap of those people in the lower income levels who don't receive any marketplace subsidies because of the way the act was written, and that has not been fixed. So basically there is a big gap in Tennessee and many southern states because we did not expand TennCare. If anybody ever tells you that healthcare is not political, they would be wrong. Who are the uninsured? In Hamilton County, most of them are working adults and low-income families. In 2017, we had 32,303 people in Hamilton County who were uninsured. 71% employed full or part-time, 74% living in family households. And across the state, this is if you're not familiar with the Sycamore Institute in Nashville, you should be familiar with it. They are doing wonderful, wonderful research and reports on a whole variety of social issues but including looking at things like spending on safety net programs, healthcare insurance, and things like that. So that's a really wonderful resource. But some residents are more likely than others to be uninsured: men, Hispanic community, younger adults, unemployed, and those with less education and income. And that holds true in Hamilton County. These are just a few demographic facts from the 2019 Hamilton County Community Health Profile that's done by the Regional Health Council and the Health Department. So it's very interesting. Sometimes those who are uninsured are not who stereotypes might suggest. So the other thing, and I'm so glad to hear the topic of this conference, because so much of health isn't just access to care. Health behavior has a huge indicator, and more than half of premature deaths in America are caused by health behaviors or the really indirect impacts of socio and economic environments. So it's a much more complicated issue than just whether we can have access to healthcare. That said, allowing people to have access to healthcare has been a big part of my life's work over the last 20 years. So the challenge, we are blessed in our community of primary health care centers that provide great primary care, but often they've been limited in access to specialty care, lab testing, hospital services. And so as a result, people often had to wait until they were so sick they could go to the emergency room and it was urgent and they could get surgery, get a condition treated through the emergency room. So the Project Access model was really created to bridge identified gaps in the healthcare delivery system. When we started out, our doctors thought, we're going to build a clinic. Let's do primary care. And I said, let's do a needs assessment first. And so that's how we really identified our model, that we needed to support the primary care systems that already advanced. When you're looking at the whole issue of how do you provide access to care for uninsured people, there are a lot of different approaches. So one approach certainly is insurance through the marketplace or through employers. Some clinics bringing specialists to the health centers. Volunteers in Medicine does that. We have a couple specialists who will do some orthopedic screenings at the Volunteers in Medicine free clinic here in Chattanooga. They're free clinics. We've got a lot of free clinics in Tennessee that get some funding through the state safety net grant programs. And some of those are open one day a month. Some of them open multiple days a week. And then the newer model that started emerging about 25 years ago is the whole idea of a volunteer specialty care network. In Tennessee, we have when TennCare was revamped, and in Chattanooga, 12,208 people lost access to TennCare. The state, as a temporary measure, created a safety net grant program to provide some assistance to programs like Project Access and Volunteers in Medicine and some other clinics that were providing of access, because they knew we were going to get more patients when those people were disenrolled from TennCare. So right now, the safety net grant program is assisting 237 programs in 89 of Tennessee's 95 counties. Those programs include federally qualified health centers, community and faith-based clinics, Project Access initiatives, and dental programs. And then in the last 2 years, there's been a move to incorporate dental care more within primary care settings. And some clinics and programs are actually starting to be able to incorporate mental health resources into their programs. This is just a map that makes my heart sing. These are the locations of the safety net grant programs throughout Tennessee. And this is actually a map from about a year ago. So there are a few more programs that have started since then. So I think that's really pretty wonderful. I'm the policy director for the Tennessee Charitable Care Network. So we work a lot on funding issues and policy issues to help support and move our clinics and programs like Project Access forward. So in our community, we are really blessed. We have a lot of really good primary care providers who do a lot of work for to serve the uninsured. Some are free, some are a sliding scale, but all provide access. So the health department's got 4 different, well, actually right now 3 locations with clinics that do some combination of primary care and other services. The Homeless Health Care Center is a FQHC lookalike. Sempa Community Care is doing great stuff. Cherokee in other communities is an FQHC. Memorial's Community Health Center. Clinica Medicos is a newer arrival. And if you want to learn more about culturally competent, high quality care, check out Clinica Medicos. Kelly Arnold has done an amazing job over there, and it is a really great program. Erlanger's got 3 community health centers. LifeSpring Community Health mainly works in pediatrics. We do a little bit for them, and then Volunteers in Medicine are the main programs within our community. So what I was supposed to talk about was Project Access. Project Access is essentially a clinic without walls. We coordinate healthcare for low-income uninsured patients by organizing the doctors, recruiting other partners to provide healthcare before it's a crisis and they reach the ER. So we really try to minimize ER utilization by getting care earlier in the disease state. The bottom line is doctors have always provided charity care and hospitals have always provided charity care, but doing it through the ER is the most expensive and really least compassionate way to do it. It is much easier to take care of people earlier before they're in crisis. And the positive thing for physicians is maybe they'll be able to take care of them during their regular surgery schedule instead of 3 o'clock in the morning when somebody's had a strangulated hernia. So it's just a better program all the way around. We provide a full continuum of care. We have more than 1,100 volunteer physicians and providers. All 3 of the hospital systems participate and donate services to help our neighbors. And we also refer patients to other needs that we may not be able to meet. So this is kind of our roadmap. The uninsured population comes to us through physician offices, our health centers and clinics, because people usually are not, they will try to self-diagnose, but most of us aren't that good about figuring out what we really need. So we get calls from patients who haven't seen a doctor and think they have a problem. We connect those folks first with a primary care home. And our staff does a really great job of figuring out where does a person live, where have they received care in the past, do they have an existing relationship with somebody, and if not, we'll connect them to a primary care home that can meet their needs and is most convenient and efficient for them. So in Project, when we get those referrals, we review their eligibility, we provide healthcare coordination and case management, we help figure out how to navigate the health systems. We recruit and coordinate partners. Almost every month or 2, we get some requests for something we haven't done before. And our staff are really great at finding new resources and helping people find a mission they didn't know that they had to care for this population. So we kind of perceive that as a big part of our job. The cool thing about these networks is that Project Access also is a critical partnership to expand primary care access. Buncombe County, North Carolina, the Asheville area was the first Project Access, and they got, it was such a cool model. They got some startup funding in part to do some longitudinal assessments. And they discovered with their main clinic that having access to specialty care actually increased the capacity of that clinic. So instead of having to see a patient 5 or 6 or 7 times until they were sick enough that they could access care through the emergency room, earlier in the disease process, they could access care, opening up all those appointments that otherwise would have been used on frustrating follow-ups while the patient got sicker and sicker. They discovered that it really made a huge difference in the efficacy, and they were able to increase the number of patients they served every year without even increasing staff because of that single point. And so That, I think, is one of the real values of Project Access. This is a list of the folks we partner with in the community. We're now working with the Bradley County Medical Society. All the hospital systems participate. We have a vibrant network of referral partners. We have physical therapy. We have access to a wide variety of services. And when I say that, I also want to make one caveat. And that caveat is, if you have health insurance, the best insurance in the world, and you need to see a neurologist, it's probably going to take 6 months to get an appointment. We have huge shortages in some specialty areas. And so we do pretty well getting our folks into the care they need. That doesn't always mean that there's not a wait. There's a wait if you have insurance. It's kind of the same situation. To qualify, patient must live in, right now, Hamilton or Brownlee County for at least 90 days before enrolling, have a family income 150% of poverty or below, not qualify for other health insurance or other benefits, and have a current medical problem and be referred by a participating provider. So it's pretty straightforward. This is kind of a snapshot of our patient demographics. Not surprisingly, we have a lot of older patients. We have a lot of patients who've worked most of their lives and have usually had workplace insurance. But as people have been downsized or had health issues that led to them being unable to work, they often find themselves having to come to us for help for the first time ever. And we try to treat every patient with dignity and with respect and with compassion. Our folks are unhealthy. A lot of them are pretty stressed out. Tobacco use is much higher than we'd like to see it. Obesity, physical inactivity, and we have a lot of chronic conditions among our patient population. And we work with all of those. We try to connect patients to diabetes management programs or smoking cessation programs, and we have different resources we provide to help connect them to resources within the community. So how does Project Access work? We better coordinate what doctors have always provided, and that lets the doctors treat more uninsured patients. They can spend all of their donated time treating somebody and not making phone calls to ask a buddy or a partner to help. It's a vastly, and this program was actually created by a surgeon in Hamilton County. Joe Kofer is a stereotypical surgeon with a heart of gold, and he just felt there had to be a better way. Probably one night after operating in the middle of the night, felt there had to be a better way to take care of people, and he set out to find it, and that's how Project Access happened here. We track everybody. We have a comprehensive database. It's kind of an EMR. It helps us track the volunteer commitments and lots of other things. We receive claims data for each patient for care that's provided. Patients receive an ID card that says we are not insurance. Everybody's donating this care, but it lets and our partners treat us as if we were a payer, generate the HCFA or UB forms, the claims information, send that to us, and then write it off as charity care. To me, that's the biggest miracle of the whole program. And so that's worked really, really well. And let me keep zipping on. We screen people at our offices, or they can be screened at a participating clinic. Participating physicians can refer patients to us. A lot of times, some of our specialists like this because they'll have a patient who's got an issue. They're seeing them for free, but they've got an issue that they can't treat themselves. And so anybody who participates can also refer patients for us. And we do try to direct patients to other services if they don't qualify for whatever reason to our specific. So our staff, it gets up close and personal. We provide really good care coordination services through enrollment, schedule appointments. We make follow-up phone calls to remind patients about their appointments. We follow up to see if they did go to their appointment and if they need a follow-up appointment. So we really try to help folks. I find the healthcare system often confusing, and I've been working in it now for 20 plus years. So folks who are uninsured, who are worried, just really worried, it's even more confusing, I think. So we really try to mitigate all of that. The cool things about Project Access, it gets more people involved in providing charity care. It can be more equitably distributed between all the volunteer physicians. It obviously has a really positive impact on patient health, and there's some accountability. We reinforce with patients when they're supposed to see primary care or their specialist, and when they're not supposed to go to the emergency room, because that's the reason the hospitals want to participate, is it gets people into a standard system of care rather than utilization through the ER. And it's really cost effective. I mean, we're able to treat a lot of people at a very reasonable cost. We currently have over 1,100 volunteers. We have directed more than 22,000 people to services through our program since we started. We have around, and this number changes almost every day, but the last time I checked a few days ago, we had 507 people enrolled. People typically are enrolled for 3 to 6 months, whatever the expected duration of care will be for the condition that they came to us. It's springtime in Chattanooga, so I'm sneezing and frogging. We helped almost 5,000 people in the 2019 to 2020 fiscal year. And the value of care that's been donated since we started is $214.6 million. That's by physicians and hospitals. And this program also has a positive economic impact on the community. And I'll show you another slide in just, let me go to this. Basically, in order to provide these services, supplies are purchased, utilities and staff are paid. So there's a significant ripple impact. So the Chamber of Commerce estimates that the existence of this program's had basically a $32 million economic impact on our community. So kind of a bonus benefit. In our last assessment, about 18% of our patients leave us and are now covered. Some of them are with us until they qualify for disability coverage. Some of the people are older, have got very serious issues. And so we try to help them until that moment that they qualify during that long waiting period. Most of our patients say that they've got better health than compared to before this. A lot of them have fewer restrictions. A lot of people have been able to go back to work. It's really a pretty incredible, it's a really incredible thing. Some of the stories yesterday, I missed her, but one of our early patients was a woman named Kathleen. And Kathleen was in her 60s, and Kathleen has given us permission to tell her story. She was in her 60s. She had an adult disabled son she cared for. She worked full time. She had 2 separate home health jobs. She's a home health worker, and she didn't qualify for health insurance either place. And she was losing her vision. So she was, through us, able to get the surgery that she needed. Her eyesight stabilized. She was able to continue working. And the day she qualified for Social Security and was able to get Medicare, she brought us a $25 check to thank us. And every year, Kathleen comes by the office and contributes $25. She's still working and she's still caring for her son. But she couldn't have done those things without the care she got through Project Access. It's very cool. And my staff never lets me talk to a patient because I cry. It's the way that it is. Yeah. So I said, and I'm probably going way too fast here, but I said that Project Access, we helped start the other other project access programs in Tennessee. Just a minute, I'm going to sneeze. Sorry about that. So there are 4 other project accesses. This year, Project Access West is starting. The State to Health Department is strongly urging and helping us expand our reach on project access. That's not the solution to our healthcare shortages and our issues, because we are asking a lot of people to do a lot more stuff for free. But it is an important resource, and we try to be respectful of the resource, and we try very hard to use the resource well. There are a couple organizations you may want to know about. The Tennessee Primary Care Association is a state organization of federally qualified health centers and similar programs. And then the Tennessee Charitable Care Network is a network that includes project access, free and charitable, faith-based and community-based clinics. And those are programs like Volunteers in Medicine in Chattanooga. We have a kind of a special relationship with with Volunteers in Medicine. For those of you who don't know about it, it is a free clinic. It's located over by Eastgate Mall. They provide a full range of primary care services using volunteer physicians and nurse practitioners. They've got a great relationship. And as Amber said, she was involved with that wonderful program. So it really is a beautiful program and a great resource in the community. So I encourage you to learn some more about that. And then I'll come back to this. When we were starting, one of our physician recruiters was a recently retired neurosurgeon, Chuck Sternberg, and his favorite proverb was "Many hands make light work," and that's kind of the underlying principle of project access. We try to bring many people to the table to provide compassionate, quality, coordinated health care. And then my favorite quote, it's on my desk: "Statistics are people with the tears wiped away." And so all of those demographic numbers, there's a face with each of those people. And I know that what you're doing, and the reason that you're at this conference today, is because you also have that passion and have that compassion and have that interest in service. We really are blessed to be in Chattanooga because we have I'm going to sneeze again. I'm sorry. I'm so sorry.
We totally understand allergies in Chattanooga. It's okay.
Okay. My cherry trees are all blooming and I know they're going to get frozen, but I think I'm allergic to my yard. We really are blessed in Chattanooga because there is a collaborative spirit that's really not seen in every place in the country. And so we're really very fortunate by that. And so I think we have been able to create an effective safety net. It's imperfect. There are still gaps. There are still holes to be filled. But I really have to salute the people who labor in these fields, and y'all are amongst those, because it's very important work. It's very important work, and it's part of what makes Chattanooga the community that it is. So I just salute all of you on the call. So anyway, that's, in summary, fastest I've ever done it. That's a project access story. Are there any questions?
Thank you so much, Rae. Yeah, and it's super easy to work with. So for those of you who are still students and haven't graduated yet, and again, it has been years since I've worked with Project Access, but y'all were just phenomenal. And that was still kind of in the early stages. That was early days too, because
yep.
I was at VIM in 2005. So
yep.
Yeah, it was early days of you all and us as well. But everyone is always so responsive at Project Access and so easy to talk to and to coordinate care with. So that, from a provider standpoint, I was so appreciative of that.
Thank you.
And if you don't mind, I typed in the chat box. I did the 2 web pages that you had for the Tennessee Primary Care Association and the
Awesome.
Tennessee Charitable Care. So that is now in the chat box. If anyone is cutting and pasting and putting these resource links into a Word document.
And then I see a question, do we utilize an EHR system? And do we leverage telehealth for visits? We use a system that was developed for Project Access programs. It's called Charisma Salus, which means the gift of health in Latin. And it's basically an EHR system. We track all of our patient appointments. We collect basic demographic information. We do pre-surveys and post-surveys on a variety of factors to try to help us monitor, how our patients are doing and how we're doing. 2 other important things to know. We were able to get the Tennessee General Assembly to extend liability protection under the Volunteer Healthcare Services Act to, it used to be site specific. So if you were providing charity care at Volunteers in Medicine, for instance, you had some significant liability protection. We were able to get the legislature to extend that to any coordinated program like Project Access. So we have to document all the visits, everything that happens within our Charisma system. And that said, there's never been a liability. There's never been a case filed against any volunteer physician since this program started, or in any program in the country, but it's a legitimate concern for providers to have. So licensed providers do get protection under the Volunteer Healthcare Services Act. Any other questions?
I'm looking for raised hands in our.
I have a raised hand, just a question about clarification about who qualifies for these services. Rae, you said, I heard the figure 150% below the poverty line. Is that what you said, or did you say at, or can you say like any kind of, what was that?
150% of poverty is our income guideline.
Do you have an idea of what that figure actually is, just in monetary terms? Not everybody knows. I'm sure I could look it up too, but not everyone knows the poverty line. So if somebody is referring to your services, that we have an idea of the income threshold.
Actually, I just had to look it up yesterday because they change it every year. I think it's about $28,000 for a family of 3. I hear footsteps coming. Somebody's probably coming from Project Access to give me that number. But
I was curious, what it is for an individual, because I also looked that up recently, and it was like, I thought the number that I saw at a glance was 24, and I was shocked. I think $24,000 for an individual is not bad money, consider it. So interesting if that's the poverty line now.
For the poverty guideline for one is $13,590 at the poverty guideline. So 150% of poverty is $20,385 for one person. And it's
13,000 something. That was
the poverty guideline is $13,590. I'll have to put this in the presentation before I give it again. So one person's $20,385 and $34,545 for a family of 3. And if you're seeing what's happening in rent in Chattanooga recently, it's challenging, really, really challenging.
Ray, I would ask you, what are some of the things you have found that work well in partnering with other providers and with other service organizations? Because I think that's something when we're in primary care, we need to know about these different resources, but also when we're trying to partner and say, hey, how can we help you or how can you help us? How do you do that?
Um, it's we're very relational over here. We try to we want to help. We want to help absolutely everybody. We really do. Sometimes we have to triage a little bit. When you have healthcare shortages, as we have in some areas, so sometimes we try to, if we know that we're going to have 90 surgery appointments available, we try to kind of spread those out because we could honestly use them all in January. So sometimes we have to triage. We try to be very supportive of our provider partners because sometimes a doctor will call and say, you know what, I just can't take anybody for 2 months. I have a partner out on maternity leave and Joe's on a mission trip and they're really, really short staffed. So we try to really understand where our physician and practice partners are coming from. And we try to, we do try to communicate very well and very frequently. So we'll staff follow up regularly with a clinic on the referrals that we get to let them know the status. The biggest challenge I would say we have is when we get referrals from clinic partners. Sometimes it takes multiple phone calls and it can take a long time to get the patient to actually come in and finish the enrollment process. So we do get some safety net grant funding from the state and different funders. And so, we've got kind of standards and guidelines we're expected to meet. And we do validate financial eligibility because we're asking hospitals and doctors to trust our charity policy instead of using their own charity policy. So it's a much smoother process for our patients, but we're honor bound to validate that. So I think the biggest thing is we try to communicate directly. If somebody needs something we don't have, we'll tell them, but we'll go out and try to find it. And so we really do value open and honest feedback. Everybody makes mistakes, and I'm sure we've made some mistakes. So anyway, it's challenging. It's a huge amount of work. People say, well, why do you need to have staff if the care is being donated? I'm like, well, if somebody's having a surgery, they got to have a surgeon, they got to have a hospital, they got to have a pathologist, they got to have an anesthesiologist, they have to have a follow-up appointment. And so we have to have people who get all that stuff arranged and help coordinate all of that. And so it is a really labor intensive, and increasingly we're really trying to focus on the broader social determinants of health, look at things like food insecurity, make other referrals to some of the other things that can help our patients live a healthier life. So the staff's they're very, very devoted, and they really love their patients. As I know all of you do. It's hard when you can't do everything for somebody.
It is, but it's amazing the services that I think, like you said, Hamilton County is really, really good about taking care and providing care for our underserved, underinsured, homeless populations.
No, it is really great. And we sometimes will help. So we just try to be a really great coordinating hub. So recently, one of our hospital partners asked us to step in and help coordinate a certain kind of service that was out of the scope of what we do. And that's hospitals are so important to us. So of course we developed a new process to coordinate that. So that's the other thing, is we're really open to new kinds of partnerships and new relationships. So Tanya Williams is the day-to-day project access director. She does a great job. And we have a really lovely staff. Alonzo Jarrett as our assistant manager, and he's just a beautiful human being who it has great relationships with all of our clinics. So it's a wonderful, wonderful team.
Yeah, really is. Thank you so much, Rae. Farron is raising her hand.
Hey, Farron.
Hi there. I was just looking up some of your, just some quick stats really to what you had to say, just to share with some of our students and providers too, about the income level. And it's, you said for an individual about 13, the poverty level is 13 something thousand. So you accept somebody in the 20s. The median rent in Chattanooga right now, the average rent for just a 1-bedroom, so for a single person, is about 1,150 or around then, a 16% increase from year to year. And on top of that, only less than 100 apartments available. That's so the availability of actual housing in that area. So even at that income level, you're talking about over half of your rent going just to housing, leaving very left for even utilities, let alone medical costs. So sometimes we can hear figures and sound that they can sound like, oh, it's actually quite a lot. But when you start looking at just the cost of shelter, that number goes down really quickly, and you add any kind of medical expense on top of that, and you would be looking at homelessness. And so I just wanted to clarify, put some real numbers to some of those situations that you were bringing up. Thank you for that, Rae.
Yeah, well, and that, thank you for pulling that number. Yeah, it really is. I mean, you know, one of the things I say about volunteers in medicine, and Southside Dodson Avenue also does a great job, and I'm sure others do. I'm not negating. It's just some programs I'm more aware of what they do. Volunteers in Medicine does a really great job helping diabetic patients, especially, get all of their maintenance meds. And so some things, I mean, the cost soaring for diabetic supplies in medicine has been really shocking in the last 3 to 5 years. So it is really, really difficult. It's really difficult for people. And we're seeing a lot of problems now too with the $5,000 deductible. I mean, you might as, you know, that's a fabulous resource to have if you do have a hospitalization, but for your day-to-day stuff that you need to take care of, that's almost like being uninsured.
It really is. And that's what I've seen a lot. And I'm sure some of our other providers and students who are working in underinsured areas are seeing. And it's so important to ask, do you have insurance or not? Because I almost feel like I can do more for some of my patients who don't have insurance because of all the resources we have than if they do have that 5,000 deductible, because I feel like that is almost if something catastrophic happens to them, not if they need a CT or an MRI or, you know, lab testing or whatever that they're going to be receiving these huge bills for that they can't afford.
Yeah. And you know what, Amber, that's probably a really good topic for us to have a future conversation. Recently, several of our partner clinics that are smaller, faith-based or charitable clinics said to me, what are some new models? How can we start to figure out how to fill some of these new gaps? And I think it'd be a really great project for us to look at. How do we take these models that currently exist? How do we look at that issue, especially with the deductibles? And what are some ways that we can kind of mold to be able to address some of that? So you can put that in your to-do list and we should talk.
Well, I was actually, there's something else we should talk about too, but I will, yes, absolutely. I will be reaching out to you again. Any other questions? Again, I'm kind of scrolling through, making sure nobody has raised a hand or nothing in chat. All right. Thank you so much, Rae. It was really great to see you again, and a good presentation, good information. Always good to know resources in our area, and you know, our students don't always stay in Chattanooga, and as nurse practitioners we move around, so know that if we move to other areas of Tennessee that there are other project access type opportunities available. And if there aren't where you live, maybe that's a project you might want to take on in your community, is how do you develop a project access? And I'm sure Rae and her team would love to help you on that journey.
We have a great resource guide, kind of how to do it. We put together in the early years of the program. So keep me posted.
All right, awesome. Thank you so much.
Thank you.
So
Take
let's give a
care.
hand to Rae. Thank you. Hands up or shake hands or check marks or whatever you want to do. So thank you, Rae, for taking time out of your morning to be here with us.
Thanks. Let me unshare my screen here.